Okay, so thank you very much. The topic is long-term protection in high thrombotic risk patients. And just 1 minute about myself. I did DM from, as already he has said, but I did my DM from Banaras Hindu University. Then I did fellowship in France, interventional cardiology under the great man Alain Cribier. He was the pioneer, in the TAVI, transcutaneous aortic valve implantation. So that was a very good experience. Then I became a assistant associate and professor of cardiology in a hospital in Hyderabad, and almost now 30 years, and have done almost 5,000 angioplasties and pacemakers and double chamber, and then we have put AICDs and we have done CRTDs, and by chance I was supposed to do the congenital heart, ASD, VSD, PDA closures, because that was compulsory in Madhya Pradesh, so I learned that also. In Firozpur, I am here for last now 10, 11 months, and we did a lot of cases. Actually, last month we did almost 54 cases. Out of that, 2 pacemakers and 1 ASD closure, and remaining angioplasties. And coronary artery disease is so rampant in Punjab. Almost you do any angiogram, and then he has a plaque or a significant disease. So it's very common, and then almost one left main angioplasty we do every month. So you can understand. So most of them are complex disease, and hence we have to, the topic is that should we give Brilinta beyond 1 year, and how much dose, and all that I will come. And as you know, what I do is I always to relieve the anxiety of the listeners, I just tell the conclusions, in the beginning, so that you don't get anxiety, and then I go through the picture. So the topic is long-term protection in high thrombotic risk patients. There was a trial in 2009, Plateau, which established that ticagrelor, Brilinta is better than clopidogrel in preventing, in reducing myocardial infarction, cardiac death, and other disability. So that was the landmark trial, Plateau. And after that, it went on, and then finally, the question, there was a debate how long it should give, and then for almost many years, it was, that you give for 1 year, DAPT for 1 year. That was the thing. But then again, from 2015 onward, there was a Pegasus trial which showed that if you give, ticagrelor, Brilinta beyond 1 year, and with low bleeding risk, it has very significant benefit again in myocardial infarction and death, and all cause death and vascular death. So this is the summary, and then we will come to the slides. So actually, the 90 milligram BD ticagrelor for 3 years has shown much benefit, and but more bleeding problems, but non-cardiac bleeding, like bleeding in the brain and GIT bleeding. So, but if you reduce the dose to 60 milligram BD, then it helps in ischemia. That means it helps in myocardial infarction, other the parameters, and but reduces bleeding. 60 milligram BD. So this is summary, that if we have a complex patients, we have to give longer, treatment for 3 years, and maybe if high bleeding risk, give 60 milligram BD. So this is the risk. But this is the summary, and then I will go slide by slide. Please, next. Okay. So this is, this is patients who were event-free for the first year following the MI, suffered subsequent MI, stroke, or death. So it just shows that generally we think that after 1 year there is a risk, and after 1 year there is no problem. It shows that the risk of MI, stroke, and death is even there, even after 1 year. Next slide. Next. Who is the high thrombotic risk patient? Do we encounter high thrombotic risk patient commonly? Yes. We have, I think the next slides will show that there's a high risk, Now, there are two criteria, clinical and procedural. Clinical means a patient with diabetes, number one, renal dysfunction, peripheral artery disease, okay, concomitant other inflammatory diseases. These are the clinical risk factors. And procedural is stent, more than 2 stents, 3 stents, long lesion, bifurcation lesion, CTOs. So all these will fall into the complex coronary disease and complex intervention. So obviously the thrombotic risk will be higher in these patients. Next. Next. So again, the same thing is coming. The type 2 diabetes. I mean, clinical risk factors are type 2 diabetes mellitus, multivascular disease, prior MI 2 years back, peripheral artery disease, age 65, more than 60, CKD. So these are the thing, and then the procedural risk factors are 3 coronary stents or more than 3, and bifurcation, total stent length 60 mm, treatment of CTOs, unprotected left main, in-stent restenosis, and severely calcified lesion. So these are all, this shows that they are all high thrombotic risk. Next. Okay, the short, this shows that in the short term and in the long term, they are at high risk. See, this is showing in the 72% higher MACE and higher stent thrombosis and higher VMI. So what he says, patient who had complex PCI had significantly higher rates of MACE, 7.5, 7.9 versus 4.6, myocardial infarction 3% versus 1.4, and definite ST, probable stent thrombosis 1.2 versus 0.4. So if you give ticagrelor, so these all the risk for MACE, that means MI, stent thrombosis, and death also must be there. So they are reduced with the doses of ticagrelor, either 90 BD or 60 BD. Next. Now, do we encounter high thrombotic risk patients commonly? Yes, it's very common. Come next. So 50, it's very common. 53% of the patients have 2 or more concomitant high risk factors. It is Sweetheart's study, and it's recent actually. It's 2020 something. Okay, next. How long and high is the ischemic risk in high thrombotic risk patients? Okay, next. So see, high thrombotic risk patients, the MACE, this cardiac and CV, brain. One C is cardiac, one C is cerebrovascular. So see if the patient is high thrombotic risk, see the red line, the complications or cumulative evidence is incidence much more. Next. Acute management of HTR, high thrombotic risk patient, with the appropriate oral antiplatelets. Okay, next. Okay, comparing the clinical outcome of 3 OAP agents. There is a clopidogrel, there is a prasugrel, and ticagrelor. Okay, now we'll see. Deaths, cardiovascular death, 7% in clopidogrel, 11% in see, actually it's 0.93, and the reduction is 7%. 0.89 prasugrel reduction is 11%, and maximum 21% reduction in ticagrelor. MI is 0.7 in clopi, and prasugrel little more, 0.76, and MI, and it's 16% reduction in ticagrelor. And death, minus 17 in clopidogrel, and 5%, and 20%, 22% significant reduction with ticagrelor So all the parameters, death, MI, and all-cause death is better with ticagrelor. Next. Now, benefits seen as early as 30 days in patients with ticagrelor extending up to 1 year. Again, this is all plateau trial, and see the green, the green, yeah, green is clopidogrel, and incidence is ticagrelor is this, what is this called, violet color. So it's 5.43% in clopi and 4.77 in tica. And next is what, cumulative incidence of, this is day after endomite, this is day after, this is after, this is up to 30 days, and this is 30 to 330 days. Again, almost similar, 6.6% with clopidogrel and 5.28% with ticagrelor. Okay, these are all no, this is New England Journal of Medicine in 2009. It's plateau only. Okay, next. Next. Okay. So ticagrelor provides 60% relative risk reduction in MACE among bifurcation PCI. So now they are coming to the specifics. So bifurcation PCI, the ticagrelor provides 66% relative risk reduction. So it's very significant compared to clopi, and no significant difference in major. Again, there is no significant difference in the major bleeding in the cardiac cause, but they have more bleeding in the GI, GI or brain, but still it is less than 1%. Okay, next. Tigers trial. Ticagrelor improved coronary blood flow in CTO patients. So now this is a this is a absolutely different dimension. This Tiger trial was done on CTO, chronic total occlusion, and they found that compared to clopidogrel, the ticagrelor had a better effect on vascular platelet reactivity. Okay, so platelet reactivity was better, and so that the vascular, the dilatation of the vessel was better after CTO with ticagrelor compared to clopidogrel. Next. Now, evidence with ticagrelor from RCT and R. So obviously, there, now we have evidence. We have the biggest trial is Plateau, biggest trial which came in 2009. And the other studies demonstrate that patients with ACS continue to be at risk for ischemic events well during the first year. So that's why this Plateau trial, and the Plateau trial was almost for 1 year, and they clearly that was the first trial which clearly demonstrated that the ticagrelor is better than clopidogrel in myocardial infarction, death, all-cause mortality, vascular mortality. But the major bleeding was similar. Major non-cardiac, bleeding was similar, but the cardiac bleeding was less. Okay, next. No, major bleeding, cardiac bleeding was similar, but the non-cardiac bleeding were more, like GI bleed and brain bleed was more. No, rationale for DPT fatigue for 12 months in ACS. So evidence with TO for RCT trial, the efficacy, again this is the Plateau trial which actually established. So we can go ahead. Next. But ischemic risk in high thrombotic risk patients extends beyond 1 year. So for a long time it was established that you just give DAPT to platelet agents for 1 year. But then again, the like Pegasus trial showed that even if you continue beyond 1 year, maybe up to 3 years, there is still a very significant benefit, particularly with ticagrelor. So next. So underestimation of long-term ischemic risk. Yeah, that's the thing. We always underestimate that. That was the trend, that just give for DAPT for 1 year, and then after that you switch over to aspirin, and that will be okay. But the Pegasus showed that the incidence of risk, myocardial infarction and instant restenosis, all were high if you stop DAPT after 1 year. So that's why the concept that give it for 3 years, and then this Pegasus trial gave 90 milligram BD for two doses, 90 milligram BD and 60 milligram BD, just to see the bleeding. If the bleeding risk is less, you give 90 milligram BD. If the bleeding risk is more, then you give 60 milligram BD. That was the thing. So cardiovascular, then what happens? See, if you give standard DP to 12 months and 6 months, cardiovascular death, again diabetes and non-diabetes in both. You see the dot is diabetes and straight red is no, standard DPT for 1 year, and the diabetes prolonged DPT. So it's a prolonged DAPT. That means for 3 years, definitely reduced cardiovascular death, myocardial infarction, and composite bleeding events. The composite bleeding events were actually prolonged, prolonged DAPT were almost similar. So it was little higher, but it was more of non-cardiac in the GI or brain. So there was not much benefit in the if the patient has high bleeding risk. So obviously a high bleeding risk patient who had prior CVA or already history of peptic ulcer, so it was decided to either not put them in the trial or give 60 BD. Next. So Korea, okay, there, Korea people did a like Grace trial in the West, registry actually, the Grace registry in the West. The Korea did a Kamer NIH registry, and they also what they say, repeat PCI procedure were performed significantly more frequently in the Clopi group than in the Tika group. So their conclusion is that if you give clopidogrel, the chances of more repeat PCI will be more compared to ticagrelor. Next. So ticagrelor plus aspirin showed 16% risk reduction in MACE versus aspirin alone. So again, this is plateau trial knowledge. Next. This is Pegasus actually. Pegasus also doing the same thing. Ischemic, practical method to look at the bleeding and ischemic risk together, more than risk factor patient selection. Okay, come next. Patient selection algorithm for long-term DAPT, post hoc, or Pegasus. Okay, these are the steps in step 1, 2. Again, if there is a more risk factors, MI, PAD, diabetes mellitus, multiple risk factors, and there is another group, high bleeding group, and then the low bleeding. So, the purpose is to, put different dosage, like Tika 60 BD for the high bleeding risk, and then 90 BD for the low bleeding. Next. Count the number of risk factors among LBR, low bleeding risk patients, and patients with more risk for Tika versus ticagrelor provides significant reduction. Okay, so this is low bleeding risk, MACE, Tika 60. Okay, so see in the low bleeding risk, again it's 8%, 9.9. So that if you give ticagrelor 60 BD, it is less. All the MACE, all the major adverse cardiac events were 8%, and if you don't give Tika, then it's 9.9%. Major bleeding. Okay, let's see this. It will be interesting. Major bleeding is little more. 2% in the Tika group, and 1%. So it's significantly more. Relative benefit of Tika Gulal treatment varied according to the number of ischemic risk factors present, with greater net benefit observed in patients with low bleeding risk and at least 2 ischemic risk factors. So, the same, it says that ticagrelor, you can give it in a low bleeding risk with 2 ischemic risk factors, and there is a benefit. Next. Again, it's same signal benefit in LBI patient with 2 risk factors until beyond 1 year. So this is very clear. Again, now this is a Pegasus trial. Significant mortality benefit in low bleeding risk patients with more than 2 risk factors like diabetes or renal failure beyond 1 year. Okay, so next. Patient selection level summary. MI with more than 2 risk factors get the greatest benefit with T60BD. So, okay. So, this is the conclusion that MI with more than 2 risk factors give 60 milligram BD ticagrelor for 3 years. It's 34% versus 20. See, the relative risk reduction in cardiac mortality is 34% if you don't give, and 21% if you give. So there's significant benefit. Next. Now these are the patients. She's a low risk single vessel disease, diabetes controlled, and he's a little higher risk. 2 MIs and 2 stents, and this one is multiple stents. So you can go on. So I think with the lower risk, we will give higher dose of ticagrelor 90 BD, and with the lower risk, we will give 60 milligram BD. So this is the way. Next. So again, this is what they're telling: assess bleeding risk, count risk factors, and 34% relative risk in cardiac model. So patient A, B, C all have more than 2 risk factors and will benefit significantly when continued on Tika 60 milligram. So all these patients who have high risk, more stents, multivessel disease, some other morbidity, diabetes, then it's better to give 60 milligram ticagrelor over clopidogrel. And anyway, in diabetes, ticagrelor is much better than clopidogrel, because clopidogrel doesn't affect the platelet activity better than Tika. Tika has much better platelet reactivity. There will be, I think, trials of CTO, chronic total occlusion, where ticagrelor after CTO shows much better vascular reactivity and much better blood flow. Next. Now, what is this? 4-year cover of Tika for saving high risk. 4-year cover of ticagrelor for saving high thrombotic risk patients. So again, you see 90 milligram is 21%, but 60 milligram it is higher because the risks are higher. Okay, so 60 milligram BD ticagrelor is good. Next. Does the choice of brand among available ticagrelors make a difference? Okay, so now we are sort of chartering in a controversial field, Brilinta versus the rest. Come, next. Can generics have outcomes different from the innovator brand? Okay, so there are always criticism that their bioavailability is same, but their effectiveness not the same. So that's what they have found. The one study from Mount Sinai shows that there is higher stent thrombosis, and then this one publication from JACC shows the generic cause 65% higher incidence of high platelet reactivity. Wow. The US FDA report found generic might be associated with 26% higher bleeding complication. Then why they have allowed why they have allowed generic? Next. Next. Is this last? Okay. So there's a, even if there is a bioequivalence, therapeutic equivalence is not there. That is what is the claim what I think the AstraZeneca is making and the other tests are making. So the blood concentration may be same of ticagrelor, but the therapeutic effect is not the same. This is what the claim is. So how to deal with this? I have my own opinion. I will tell that next. Generics bioavailability may vary between 20% to 20% negative, not less of percent. It will still be considered bioequivalent. Okay, so generics. I mean, what they want to say that even if it is less than bioavailability is less, it's still sort of considered same bioequivalent. So 45% range of variance of in bioavailability might lead to different outcomes. So this but just previous slide shows that even if the bioavailability is the same, still the therapeutic availability is not the same. So and then if it is bioavailability is not the same, then obviously there will be big problem, increased risk of bleeding and all that. Next. So I think this is the last slide, that all the big trials, Plateau, Pegasus, Atlantic, Sweden, they were done on Brilinta. There's RCT evidence, there's a RWL evidence, Brilinta 90 milligram improved, then it has 11 years experience, so generic. So you can't criticize also much, because the cost has to come down, and the government, if you criticize more, then the government will notice you. So you have to be very careful. So what I do is, wherever there is a complex patient, or maybe a VIP patient, and multiple stents and diabetes, I always prefer Brilinta, at least for 6 months or 1 year, and see. But if the patient is very low risk, single vessel, and not a very no diabetes, then I can give some this generic drug, and this is how some manage somehow. So this is what I do. Next. So this is a summary. Balancing ischemic and bleeding risk crucial. So this is very common sense, that you don't want more bleeding, but at the same time it has been established that there are ischemic risks beyond 1 and 3 years. So something has to be done. So something has to be done. That means ticagrelor 90 or 60 milligram BD has to be given, but careful about bleeding. Anemia, history of hospitalization due to bleeding are two accurate predictors for distinguishing patients at low and high. Okay, if this patient has anemia and bleeds, and then obviously is by high bleeding risk. Patient with two ischemic risk factors derive greatest benefit for long-term use of TICA up to 4 years from the skin. So obviously, if two risk factors, there will be most of the patient will have more than two risk factors, because most of them are diabetic or hypertensive, and then many times we have to put two stents, and sometimes even up to 60 millimeter of stents we are putting actually frequently. So all these will ultimately need ticagrelor, and if they are high bleeding risk 90 BD, if they are low bleeding risk 60 BD, and watch. And I think there is a product which is actually which can counter ticagrelor high dose, and if there is, I think something is coming up. I think these people AstraZeneca will tell you. Okay, case learning on HTR patient with clinical comorbidities. Okay, I think it's last, and if anyone has any question, we can go. Thank you.
Thanks, sir, for nice presentation. And please post your question in chat box if there is any question. Okay. Sir, one question. We have one question in chat box from Dr. Bhushan. The question is, what is the recommendation of class for Blitter 60 mg post 1 year?
What is the class? Which
Yeah.
so same which that's what I already said that if the if the complex PCI more than two stents, bifurcation stent, left main stent, and these are procedural. And if the patient has diabetes or CKD, then you have to give 60 milligram BD. And it has Pegasus trial has shown that it is better than 90 milligram BD. It is as good as 90 BD, but with lower bleeding risk.
Right, sir. Sir, one question by Dr. Singla regarding as he's sharing his experience. We experienced sometime dyspnea
Yes,
in
yes.
some of the patients with Tika.
Yeah,
So
yeah.
how to manage during the treatment?
Yeah, that's actually it's a problem, and it's not that uncommon. Almost 10 to 15% patients have this shortness of dyspnea. But actually, most of them, if I just counsel them that look, it will be all right in 1 or 2 months, and if I stop this medicine, then it will be very bad because your stent will close. So he understands the importance, and I have actually never stopped Brilinta. I mean, there are data that many people have discontinued, but I have never discontinued Brilinta. I'm just explaining them about counseling them helps, and I think some anti-allergic or some other drugs may be given.
Right, sir. Sir, question from Dr. Gaurav is, Doctor, in recent studies, generic Tika efficacy is varied. So is it wise to use generic, especially in high-risk patients?
Generic?
Yeah, generic ticagrelor in high-risk patients.
No. I think it's always better to avoid generic and high risk patient, and even any VIP patient, even if it's a low risk, please don't give. Please depend on Brilinta. And very when you are very safe, low risk, and not a very VIP, it's better you can give.
Great. Sir, question from Dr. Deepak. With Brilinta, bleeding risk was plateau bleeding or TB bleeding?
Plateau bleeding or?
TB bleeding.
No, there's no plateau bleeding, there's a Timmy bleeding. So Timmy bleeding, is a significant means when you need blood transfusion. Then that they call significant if you need blood transfusion. So what the Plateau had significant bleeding, but non-cardiac bleeding. It didn't bleed in the heart or no perforation, but there was more significant bleeding in the GI or brain. But that was also less than 1% actually. It was less, I mean, compared to clopidogrel, it was significant, but it was still very low, less than 1%.
Very right, sir. Sir, questions regarding Cloppy is also here. Dr. Deepak is asking, can we give Cloppy DAPT non-STEMI and low-risk ACS patients?
Low risk, DAPT.
Yeah.
DAPT means they mean ticagrelor or clopidogrel?
Cloppy.
Clopidogrel.
He's asking for Cloppy.
Okay. Now see, the clopidogrel is there are many problems with clopidogrel. Number, like we used to think that the clopidogrel resistance is maybe 15-20%. But then in many reports, it's almost up to 30%. So you can just understand that you are giving clopidogrel and you are feeling very happy that you've done a good job. But actually the clopidogrel is not working. So it's very and then there are no tests actually you can do. I don't know, there are some tests to know whether platelet, what happens about on platelet reactivity by clopidogrel. So again, it's very you'll be in dark, because you think you are doing a good thing and then clopidogrel is not working. So always high risk patients, left main stenting, bifurcation, diabetic, and always give ticagrelor and preferably Brilinta. And then, if you think that patient is very low risk, then maybe clopidogrel and aspirin.
Very right, sir. Sir, one question from Dr. Bhatia regarding duration of clopid. Sir, in high thrombotic diabetic patients, can we shift these patients to clopid after 6 months of Tika therapy?
Actually not, because diabetes, firstly clopidogrel resistance, okay, 20 to 30%, whether diabetic or non-diabetic, number one. Number two, this trial is there, the CTO trial. It shows that with this clopidogrel, there is the platelet reactivity and the vascular dilatation is not very perfect. They give adenosine and clopidogrel, and they found that the blood flow is not that good compared to ticagrelor. So if the patient is diabetic, it's better to give ticagrelor.
Very right, sir. So, sir, we have last question from Dr. Singh regarding he has appreciated your presentation. So he's saying nice presentation, sir. And he
Thank
also
you.
mentioned one question. You are sharing original product need to be preferred for VIP patients. So what about the normal patients? So they are not important.
And it's it's we are talking in a very close group. Okay,
Okay.
it's we are talking in a it's like it's common sense. It's common sense that avoid, because VIPs will go to many doctors here and there, and then your prescription will be counter checked. So the first question will come, ki, why you have not given the original product?
What is
So that's it's better to avoid that. It's not that we are against the other people, but it's a common sense to avoid problem with these people.
okay? So thank you very much, sir, for your valuable time, and thank you all the participants for joining with us. So, sir, your last comment to all the participants for today evening regarding the session, or maybe anything you need to share.
No, very actually, very good questions were asked, because many times when we do like these web, there don't not many questions. That means these people have read the topic, and it's always good to read the topic and come. So it's a good interaction, and it's good interaction for everyone, because really whenever I am given to ask something, speak something, only those days I really read and think about the product. Then I really, so it's a very good actually for me, if somebody asks and asks me to speak on something. And I was, I am for last 25 years I am speaking, I was in Dubai, and I used to speak on all the new trials like Life and Hope, and they used to come and ask me to speak. So I would speak in 2, 3 places. They would give money, of course. So, I mean, once somebody asks you to speak, then that means you have to read the topic. That is the best thing for me. Otherwise, I won't spend that much time to read.
Right. So thank you very much, Dr. Singh, for your valuable time, and thank you all the participants for joining with us. We have got last comment from Dr. Shailendra. Thank you very much, Dr. Singh, for your nice talk. So thank you, Dr. Shailendra, for your comment, and thank you all the participants. Thank you, Pankaj and Gandhiji, for taking Dr. Singh in today's session. We love to take such experience in some different topics, as we have variety of the product. Sir has expertise in heart failure also, dyslipidemia also. So we love to take you, sir, in some other topics also.
Yes, I have
Thank you, sir.
spoken on, like this Crestor also is a product. I spoke on these Vimada and Azmada many times. I was a speaker for them for many years. So anyway, I will like if you give another topic sometime.
Yeah, sure. Thank you, sir. Thank you. Have a
Okay,
nice day.
okay, bye bye. Thank you.
Bye bye. Bye bye.
Thank you.